Hello friends, today we are going to discuss non-ST segment elevation myocardial infarction. Non-ST segment elevation myocardial infarction is a type of acute coronary syndrome in which there is partial obstruction of coronary artery which leads to reduced blood flow to the heart muscle. There is incomplete obstruction, unlike ST segment elevation myocardial infarction in which there is complete obstruction of a coronary artery. Now, coming to its pathophysiology. Non-ST segment elevation myocardial infarction results due to formation of a thrombus over a ruptured atherosclerotic plaque in a high-risk patient. High-risk patient is the one with comorbidities in the form of diabetes, hypertension, or dyslipidemia. So how does the plaque rupture? So atherosclerotic plaque is made up of lipid-rich core and a fibrous cap. And there are 4 steps. First is inflammation. Inflammation weakens the fibrous cap. Second, mechanical stress. Hypertension and tachycardia increases strain on the cap. Third, rupture of the cap. As the fibrous cap tears, the lipid-rich necrotic core is exposed to circulating blood. Fourth, clot formation or thrombus. Activation of tissue factor and collagen trigger platelet activation, aggregation, adhesion. Activation of coagulation cascade which results in clot formation. This clot formation causes partial blockage of a coronary artery, resulting in non-ST segment elevation myocardial infarction. Since the artery is not completely occluded, hence ST segment elevation will not be observed on ECG, and cardiac enzymes are elevated. Now, coming to its risk factors. Risk factors of non-ST segment elevation myocardial infarction can be classified into 3 types: non-modifiable risk factors, modifiable risk factors, and emerging risk factors. So anything that accelerates atherosclerosis, it will increase the risk of non-ST segment elevation myocardial infarction. Now, coming to non-modifiable risk factors first. First of all, age, more than 45 years in males and more than 55 in females. Sex, males are more predisposed than females. And third, family history of coronary artery disease. Now, coming to modifiable risk factors. Modifiable risk factors may include hypertension, smoking, diabetes mellitus type 2, dyslipidemia, obesity, sedentary lifestyle, unhealthy diet, psychosocial stress, alcohol consumption. Now, coming to emerging risk factors. Emerging risk factors may include first, lipoprotein A, second, CRP, which is a marker of inflammation, third, sleep apnea, fourth, CKD. Now, we will discuss clinical features in a patient with non-ST segment elevation myocardial infarction. So, a patient with non-ST segment elevation myocardial infarction presents with severe retrosternal crushing type of chest pain radiating towards jaw or left shoulder. It is not precipitated by exertion. It is not relieved by rest. It can be associated with other symptoms in the form of nausea, vomiting, sweating, diaphoresis, or a sense of impending doom. Now, let's go through quickly investigations in a patient with non-ST segment elevation myocardial infarction. First, ECG. So, on ECG, we may find ST segment depression or T-wave inversion. Second, cardiac enzymes. So, cardiac enzymes such as TROP-I, TROP-T, and CPKMB are elevated in patients with non-ST segment elevation myocardial infarction due to myocardial necrosis. Third, echocardiography. With the help of echocardiography, we can detect regional wall motion abnormalities in a patient with non-ST segment elevation myocardial infarction. Not only that, we can also detect complications due to non-ST segment myocardial infarction, and it will also guide in treatment of patient. Coming to fourth, coronary angiography. So coronary angiography will help to identify the culprit lesion in a patient with non-ST segment elevation myocardial infarction. Now coming to treatment. So treatment can be classified into two parts, initial treatment and further treatment. Coming to initial treatment first. So any patient who presents with non-ST segment elevation myocardial infarction, first we need to give morphine or pentazocine in case of severe retrosternal chest pain. Then oxygen support if oxygen level is less than 90%. Then nitrates if BP is more than 90 mmHg systolic. And aspirin, P2 Y12 inhibitors, ticagrelor, prasugrel, clopidogrel, and beta blockers. Beta blockers mainly carvedilol, metoprolol, and bisoprolol, as they reduce myocardial oxygen demand in such patients. Loading dose that is given in STEMI is as follows. Tablet clopidogrel 300 mg stat, tablet ecosprin 325 mg stat, tablet atorvastatin 80 mg stat, and tablet sorbitrate 5 mg sublingual stat. Now coming to further management. The further management of a patient with an STEMI may include: number 1, anticoagulants. So patient may be started on LMWX or conventional heparin to prevent further clots. Second, high intensity statin. Patients are started on high intensity statin, that is a tablet atorvastatin 80 mg OD or tablet rosuvastatin 40 mg OD. Then ACE inhibitors and ARBs can be started in such patients. Fourth, coronary revascularization can be considered in the initial 24 to 48 hours depending upon the risk. So a TIMI risk score is calculated, and in TIMI risk score, each of the 7 factors count as one score. It is as follows. Number 1, age more than 75 years. Number 2, 3 risk factors of CAD. Number 3, known case of CAD, that is more than 50% of stenosis present in a coronary angiogram. Number 4, ECG changes. Number 5, cardiac enzymes are elevated. Number 6, 2 anginal episodes in last 24 hours. Number 7, usage of ecosprin in last 7 days. So if patient has 5 out of these 7 points, we label the patient to have high risk. We put the patient in high risk category, and patient should be considered for early invasive treatment and aggressive management. Angiography should be planned within initial 24 hours, and if the lesion is found, then angioplasty should also be done in such patients. Now we will go through the role of tirofiban in non-ST segment elevation myocardial infarction. Tirofiban is a glycoprotein 2B3A receptor inhibitor. It is a potent IV antiplatelet drug which is used in the treatment of non-ST segment elevation myocardial infarction. Indications: it is used in high risk non-ST segment elevation myocardial infarction patient, and it is most effective when it is used early and along with PCI. It inhibits platelet aggregation and improve outcomes, especially if it is used in combination with heparin and aspirin. Benefits: it reduces mortality, it reduces recurrent ischemia. Contraindications: any active bleeding, past history of hemorrhagic stroke, uncontrolled severe hypertension, thrombocytopenia. Thank you.